Good afternoon, everyone, and welcome to this afternoon's session in Value in Health Week in Wales. And I'm really pleased to introduce and chair this session where we're going to be looking at some of the approaches that we've been adopting as a finance community in Wales as part of our overall approach to value-based healthcare. When Michael Porter kicked off his original work, he used the very simple equation of value being the relationship between outcomes and cost. And many of us have moved on from then in terms of some of that definition and refined it. And we'd certainly be the same in Wales, that we think there's a lot more to measuring and describing value than just that simple equation. But he also said when he launched his sort of seminal work that cost is often the overarching problem in healthcare, but it's the one thing we know very little about. And certainly clinicians, when they come to decision making, need a lot more help and support in terms of understanding the resource implications of some of those decisions. So I'm delighted to introduce the speakers to you this afternoon who've been grappling for a number of years now with those very difficult questions of how do you do that at a local level, but more importantly, how do you scale that up at a national level, and how do you make it the way that the system works and the way that we approach the delivery, the planning and delivery of healthcare in Wales. So I'm delighted to have with me this afternoon Mr. Glyn Jones, who's Director of Finance and Performance at Aneurin Bevan Local Health Board, who have pioneered a lot of the work in Wales very early on around value-based healthcare. Glyn is also the chair of our Finance Academy, and a key part of our development approach to the finance profession in Wales is very much having value-based healthcare as a key developmental challenge for us to address, and Glyn is leading that work as chair of the Finance Academy. I'm also delighted to introduce Lisa Powell, who is Head of Business Intelligence at our Finance Delivery Unit and works very closely alongside our third speaker, Mr. Craig Davey, who's Programme Manager for Value-Based Healthcare in the Finance Delivery Unit. So I'm really pleased to have such an experienced and practical, I would say, in a sense that these people are going to try and describe how you do it in practice, but that's probably professional will be a better word. So I'm really pleased with the speakers that we've got, and there will be an opportunity at the end to take some questions and answers from all of you. So without further ado, let me hand you over to Lisa Powell, who'll begin the session for us today.
So thank you, Alan, for setting the scene so well and describing the context as to why we need value-based healthcare in Wales and why we need to better understand our resource usage. It's a real privilege to be here today, and I'm pleased to be able to share some of the great work that's taken place across Wales by both local and national teams to help understand the resources used to deliver healthcare to our population. So what are we going to talk about today? As we heard yesterday at the start of the conference, improved value is data-driven. So data needs to be at the centre of all our decision making. We'll briefly talk about the why of why we need to measure costs for value. The central section then, which I think will be the interesting bit, is when we'll describe the how. So how do we measure resources to deliver healthcare? Or as it was referred to yesterday, how do we hold up a mirror to the services we deliver? And we'll use some case studies and examples to try to keep it interesting. Then finally, Glyn Jones, Director of Finance and Performance at Aneurin Bevan, is going to give a finance director's perspective of delivering and driving forward the value-based healthcare agenda. So we're at a value conference, and as Alan mentioned, we're all probably familiar with Harvard's Professor Michael Porter's definition of value as the outcomes delivered relative to the costs required to achieve those outcomes. On the left, we've got NHS RightCare's triple value approach, and on the right, we've got a depiction of the principles of prudent healthcare which is the vehicle that we put value-based healthcare into practice by in Wales. But I think the most important thing for me is the central circle. So in order to improve value of healthcare in Wales, as Alan mentioned, we first need to understand how the resources are utilised. And we're going to describe the how over the course of this presentation. Then we need to understand the resulting outcomes for patients and understand how this fits in with the resource allocation. In order to improve the value of healthcare delivered to our population, we need to reassess in a continual cycle of review. So why do we need value-based healthcare? Summing up, there's a growing demand for services. People are living longer, have more complex comorbidities, and the growth in funding won't match the increase in demand. We need to make sure we maximise the use of limited resources, especially in these times of COVID, when our resources are being stretched in an unprecedented way. And we need to deliver services that focus on delivering the outcomes that matter to patients. So in summary, to deliver a value-based service, we must clearly understand the patient and clinical outcomes and clearly understand the costs of the services that we are delivering. Traditionally, when someone mentions healthcare costs, we tend to think about it in the context of budgets, forecast, financial plans and savings. In the past, healthcare directors of finance have gone to healthcare budget reports and looked at reducing input costs, for example, sourcing cheaper supplies in order to make savings. But when we look at what industry DOFs do, they tend to look at core processes and outputs and ways of improving quality and outcomes. So if we look at the costs of delivery of healthcare services as a whole, by understanding the resources required to deliver a pathway of care or support patients with a condition such as diabetes in parallel with understanding the clinical or patient outcomes, this is an alternative way of viewing and comparing delivery of healthcare services. So the illustrations on the slide show some alternative ways that we deliver healthcare, and attached to them all are prices which we have available to us. So we've got an outpatient attendance, we've got one of the more complex knee replacement procedures, we've got the spend per head of population in Wales, cost of a cataract pathway, an indication that we can look at the costs associated with treating a condition such as diabetes. But the diagram in the bottom left-hand corner is the most interesting one to me. It looks at the costs of a real-life patient called, let's call him Norman. So this is a real-life example. Over the course of a year, Norman visited A&E 88 times. And over the course of the year, it cost £13,327 for those appointments. So all the repeat visits seem to indicate that Norman was unhappy with most of the outcomes of these visits. So it's likely the 13,000 could have been spent on Norman in a very different way to give him a much higher value healthcare service. So in summary, if we know the costs, we can start to consider these in the context of patient outcomes and deliver better value healthcare to the patient. So just a note on variation, and it's not all bad. There's two kinds of variation. There's warranted variation, which can be thought of as justifiable or acceptable. So for example, if a particular GP cluster of practices has a high rate of amputations for diabetic patients, and it's higher than the neighbouring GP cluster of practices, there could be reasons to warrant this variation, such as a higher prevalence of diabetes and higher levels of deprivation. It's the unwarranted variation that we need to identify and address. So unwarranted variation could be due to underuse of high value interventions, such as maybe a keen diabetic nurse working with a cluster of practices, or overuse of low value interventions, such as amputations. I know healthcare for diabetic patients is complex, and this is a really simplified way of looking at things, but it illustrates a principle, and we'll look at a real life example later on. So in summary, before we get to the how, we have finite resources and ever increasing demands, and we need to understand how resources are being utilised. We need to identify variation where it's unwarranted and how resources can be used differently. And we need to help provide this information for clinicians and healthcare managers to maximise the use of resources and maximise outcomes for patients like Norman. So this is the interesting bit. How do we measure the resources that are used? We'll try and keep it interesting by including case studies and examples to illustrate the different techniques. So what are the key tools and techniques for measuring resources? We need to measure resource consumption at different levels. So I'll describe the system level approach, where we'll look at program budgeting marginal analysis and condition dashboards. And my colleague Craig will look at the pathway or condition level approach. So time-driven activity-based costing, patient level costing or PLICS, and a blended PLICS TDABC approach. So system level approach. I'm aware that there may be some people who aren't from Wales. So a little bit about how we deliver healthcare in Wales. We've got a population of 3.2 million. Since 2009, healthcare services in Wales have been managed and delivered by 7 integrated local health boards, which are both commissioners and providers of the service in their geographical areas, and they have full responsibility for the health of their local population. They deliver the full range of services or commission the full range of services, hospital-based, mental health, community services, and contract with GPs. The system of payment by results and the market system is not in operation in Wales, so each health board has an allocation from Welsh Government, which is shifting incrementally towards a population needs model. Then within each health board, we have GP clusters, which are typically groups of between 5 to 8 GP practices in a close geographical location. And the purpose of these GP clusters is to encourage the GPs to work together and develop their local healthcare system. So for the sake of comparing population healthcare at a manageable system level, we tend to look at health delivery for a GP cluster population, but always need to be aware of underlying differences due to demographics and deprivation. So where shall we start? Programme budgeting seems to be a good place to start. It's a UK standardised way of mapping all health board costs at a patient level where enough information is available across 23 disease categories. So the categories are, as you can see from here, cancers and tumours, respiratory problems, trauma and injuries, and so on. These costs are published annually and publicly available from Welsh Government Stats Wales website. So the costs are allocated based on a medical condition using diagnosis codes for acute services, and it provides a commissioner perspective at a system level, showing the total spend for the local population rather than the spend on services provided by the health board. And as we can see from this breakdown, spend per head of population for respiratory problems in the year in question ranges from £115 to £165 per health board. So let's take this a step further. Recently, some proof of concept work was undertaken with Hywel Health Board to produce a more detailed perspective of resource utilisation, which provides the healthcare for its residents. So this particular graph shows the secondary care spend on respiratory problems for all Hywel residents, regardless of the health board providing treatment. So we can see there are 7 GP clusters within Hywel in the top left-hand corner, and there are varying costs per head of population for each of the clusters. The pyramid chart on the right introduces the dimension of age bands. So each coloured band, a blue band, represents a certain age band for each practice. And over the entirety of Hywel, it's more or less 20% of total spend is spent on the 70 to 79 age group for respiratory problems. So we can see GP cluster spend ranged from £63 in cluster 5 to £81 in clusters 2 and 4. And then at the bottom, we've split the spend between males and females of different age bands. And we can see males in cluster 2, which is the yellow line on the right-hand bottom graph, have greater spend per head of population than in any other cluster. Now, this doesn't give us answers. It just gives us places to look and helps point us towards the right questions. So using this kind of population cost and cost variation provides us with an insight as to how we deliver healthcare, and also gives us an insight into service delivery variation. So Hywel leads have met with public health leads and locality management teams to explore what questions the analysis prompted. There's a need to understand some underlying differences in on-the-ground service delivery by carrying out some targeted pathway analysis, which Craig will describe later. But also we need to take into account factors such as relative deprivation of each cluster. So it gives us a bit of an overview and gives us targeted places to look. So another technique we can use is programme budgeting marginal analysis. Programme budgeting appraises past resource allocation to specified programmes. Marginal analysis looks at the added benefits and added costs of a proposed investment. And there's a very structured 8-step approach, which I won't go into now, but I'll skip to a real life example. So in Aneurin Bevan Health Board, admissions for chronic obstructive pulmonary disease were the highest in Wales at the start of this study. £16 million was spent on inhaler therapy for asthma and COPD, which was disproportionately high compared to the other Welsh health boards. So the actual Aneurin Bevan spend at the start of the exercise is described in the left-hand triangle. It was lowest for pulmonary rehab and highest for inhaler therapy. But what is the quality of the outcomes that each of these interventions provide? So at the same time, studies by the London Respiratory Network arrived at a cost per QALY, which is a cost for a quality adjusted life year for each intervention. These showed a low cost per quality adjusted life year for smoking cessation of £2,000, which makes it a very high value intervention, but a high cost per QALY of over £7,000 for inhaler therapy, making it a lower value intervention. Through the PBMA process, this information was shared between a wide group of stakeholders who participated in the programme, which included clinicians, and they chose to invest more in the high value care, such as smoking cessation and pulmonary rehab, which led to reduced investment in the low value prescribing. So since the study, there's been a 1.3 million reduction in the low value respiratory prescribing spend, and this money has been reinvested in other areas, but we'll only truly know how well the project has performed once the outcome data becomes available, so we can see the relative outcomes on patients, and that's the next step in the process. So for my final slide, I'm excited to introduce the final project, which is really still very much work in progress and at its development stage. But it's a proof of concept BI dashboard, which will link the national activity and financial information data sets with the national clinical outcome data sets. So this particular dashboard is for lung cancer. We know that for the clinical condition of lung cancer, stages of diagnosis are late and outcomes are poor for Wales. This BI tool gives a geographical visualisation of lung cancer secondary care patient expenditure across health boards in Wales on the left-hand side. But it also, on the right-hand side, helps to identify variation in numbers between the stage of diagnosis per health board and the cost per spell for health boards. If this is then overlaid with clinical outcomes information, it can help to identify variation across the population. So this product continues to be developed and can be applied to other conditions, and the hope is that this can lead to further clinically driven and directed deep dive analysis in order to better understand variation across the population. And there are a number of organisations who are keen to get involved in more detailed and targeted pathway mapping for lung cancer, which will help us to better understand variation. So I've covered some of the ways we can view variation at a population level. I'll now hand over to Craig Davey, who will describe the pathway level approach and some of the key tools and techniques that are available to support this more detailed analysis. So thanks, Craig.
Yeah, that's great. Thanks, Lisa. So as Lisa just said, following on from that overview of the system level approach there, and some of the tools and techniques, we're just going to touch a bit now on the pathway approach, and again, some of those tools and techniques we have available to support, I suppose, some of that more detailed analysis. So firstly, let's just consider a fairly simple surgical pathway, looking at a patient journey through the system, and albeit in practice, I appreciate there'll be a number of additional steps here, and it will be slightly more complicated, but let's go with this for the purposes of the illustration. And so the pathway starts with a GP appointment in primary care, which is likely to be followed then by a referral into secondary care, and this will then need to be, I suppose, processed and triaged before the patient maybe is then invited to attend, say, an outpatient clinic where they'll undergo some additional diagnostic tests, for example. There may then be a clinical decision and importantly as well, a patient choice around the appropriate treatment option, one of which in this example is a surgical option, maybe with say a specialist provider, and the other is a non-surgical option, maybe in primary or community care settings, which may be more of an ongoing treatment then rather than I suppose a one-off treatment as with surgery. So once we get to this stage, in that we've identified an area of interest, maybe using some of the tools and techniques that Lisa will have just talked us through, and mapped out a pathway we want to explore, the next question is, well, how do we cost this? So the first technique we're going to consider is called time-driven activity-based costing, or TDABC, which is an approach we've been, I suppose, testing in Wales for a number of years now. And it's an approach to costing healthcare activity that was developed by Professor Robert Kaplan and team at Harvard University, and is the, I suppose, suggested approach to costing pathways when implementing value-based healthcare. TDABC, as you can see, there is a bottom-up approach to costing, which allows us to quite easily build, I suppose, the costs around individual pathway steps, and that's the sort of thing I'm trying to get at with the illustration in the bottom right-hand corner there. And the costs themselves are based on capacity costs, which is effectively a cost per minute for various staff grades involved in the process, and then conversations with those staff at each stage around the sort of who does what, when, and for how long. As well as then building in things like the cost of key consumables and equipment used and that sort of thing. So in that sense, it's a fairly straightforward process, you know, in terms of actually doing the exercise, although, you know, it does give us as well then that much more sort of detailed and granular understanding of each of the key processes and the steps involved in the pathway and what's actually driving those costs. But as you can imagine, I suppose a shortfall, if you want to call it that, is that it can take quite some time to do this if we're working with particularly long and complex pathways. Although, as I say, that the process itself is very key in terms of engaging and bringing together then finance professionals with clinicians and managers, which is an essential part of value-based healthcare, as we've heard. And you know, this definitely helps to drive then the collaboration across the organisation. So as an example, I just wanted to quickly share with you some of the work that was previously done around the cataract pathway in Wales, and this was really the first TDABC exercise or pilot project that was done across Wales, in that it involved all 7 health boards, and at the time was something that was backed by finance directors then as a pilot area. And interestingly, despite the cataract pathway being a relatively simple pathway, I suppose when you compare it to a lot of other surgical procedures and pathways, the results of the exercise actually showed significant variation, as you can see there, across the system. And this included the identification of 17 different pathways across Wales, and within that, a 50% difference in cost if we exclude one that was an outlier. So at that point, you might think, well, okay, so what? And you know, bearing in mind the fact that this was initially a pilot exercise to look at the application of TDABC across the system, I think quite early on, you know, the work definitely encouraged some open conversations within health boards around sort of potential service improvements, looking at things like theatre lists and capacity and the number of steps in the pathway, for example. And in some health boards where they were already collecting patient outcomes for cataracts, they were also then able to look at this information alongside the outcomes and start really then understanding value. I think from a costing perspective as well, there was certainly a benefit in sort of observing clinics and theatre sessions, which certainly improved, I suppose, our understanding of some of the key processes involved, as well as helping to identify some of those key tasks or roles that may have previously been, I suppose, missed or misunderstood from a costing perspective. And by that, I'm talking about things like maybe further clarity around the different points captured as part of a theatre timing system, for example. And I think in general, you know, this sort of exercise can also help organisations then to identify any gaps in their locally recorded data as you start to work through the pathway and try to piece all of this together. So in hindsight, you know, it did teach us a lot about the benefits of applying TDABC to a pathway at scale, as well as some of those challenges then that we can be faced, and, you know, for example, having that sort of consistency of approach across the system. And a lot of these lessons that we've tried then to take forward into other exercises to allow us then to continue to develop our approach, some of which you'll see in the next couple of slides. And lastly on this, I just wanted to mention also, we're in the process of revisiting this pathway, and we're currently working with colleagues in Swansea Bay University Health Board to look at really what has changed since the original work and where they are, or where there may still be some opportunities really to develop the pathway through that value-based review, again, looking at costs and outcomes. And we're also planning to bring other health boards on board with this as the work progresses as well. The other technique I just wanted to touch on really was patient level costing, or PLICS. This will probably be more familiar to you in terms of what you may have already come across in your own organisations with costing information. And patient level costing is a top-down approach to costing that looks at allocating total organisational expenditure then to discrete units of what we'd call captured activity, right down then to a patient level, and the general principles of the process are shown in the diagram there on the right hand side. And these costs are then fully absorbed, and the process does involve a combination of direct matching, allocation and apportionment then of costs across the system. But one of the key benefits of PLICS is that the data is submitted annually as part of a national exercise, and it's therefore done then to nationally agreed standards, and this means, there'll naturally be that bit more consistency then for comparing and benchmarking outputs with a level of detail also down to that patient level, enabling us to have that detailed drill down to allow organisations then to look at costs at a number of different levels. And it also means that the information is there and ready to be used. So with all this in mind, we've started to explore a more blended approach to costing pathways in Wales, utilising really the benefits of both PLICS and TDABC as far as possible. And coming back to our simple surgical pathway that we looked at earlier, on the face of the diagram, the blended approach could look something like what you'd see on the slide there, with the green boxes being PLICS costs and the dark blue boxes being TDABC costs. The PLICS costs there are for the more, as I said, routinely captured areas of activity that will be costed as part of that annual costing exercise, and then the TDABC costs have been used to, I suppose, fill the gap, so to speak. And as you can see, these could be things like the primary and community activity, or maybe other actions and inputs that we wouldn't necessarily have identified looking at the PLICS data alone. And there are some clear benefits to using this blended approach. On the left-hand side there, as I said, PLICS can help us save time and speed up the costing of pathways, with the costs being readily available, as well as having that bit more consistency from the national standards. And as I said, that drill down ability allowing us to look at costs at various levels then. And also, even if we are using TDABC to cost some of those areas where we'll have captured activity, we can also use PLICS to validate and sense check some of these costs, and vice versa, really. TDABC, on the other hand, as we've just seen, can help, as I say, fill the gaps in some of the more traditional costing data, and through then some of those detailed conversations that will be involved with clinicians and management, we can help also to identify some of those hidden costs and maybe variation that may not otherwise come through in the PLICS data, as I said. And over time, actually the detail behind the TDABC costs can also help us to, I suppose, refine PLICS data by providing a better understanding of those key processes and ultimately informing, I suppose, better allocation and apportionment then of costs within the system, for example. And on that as well, TDABC and I suppose the pathway approach in general really also means that clinicians and managers, in seeing the cost in this way, can much better relate to the figures, and this tends to result in, as I said earlier, that better engagement then and collaboration across the organisation. So I just wanted to share another quick example with you where we've explored this blended approach, and this was an exercise exploring the total knee replacement pathway in Wales, and this was done as a proof of concept exercise actually at the request of the Welsh Orthopaedic Board. And as you can see on the slide there, the aim was to combine some of the published costing data where we had this available with some of the more sort of say bespoke costing, but TDABC in this case, to cost a full pathway down to a consultant level. And some of the key findings were quite interesting, and maybe the sort of things we've expected to see from what we'd seen with the cataract pathway and similar exercises is we've seen the community triage services, for example, varied across health boards, both in terms of the type and the cost of those services. Pre-op and outpatient pathways varied across health boards in terms of the number of contacts, the cost of these contacts. When we looked at admitted patient care, the costs of that range from, I think it was about £5,000 to £8,000 per spell, and within that there was even more variation then coming through from things like the theatre costs, as well as the cost of prosthetics then within that. And also at the sort of tail end of the pathway, post-op services included different combinations then of therapy services and approaches to the delivery of those services. So we've seen things coming through like group therapy versus individual therapy sessions, or nurse-led sessions versus therapist-led sessions. So there's a lot of variation there. And we also tried to explore, and taking this a step further, some potential opportunities around the technical efficiency by using PLICS data with other data sources that we wouldn't have maybe looked at previously. And we were able to look then at things like the impact of patella replacement and where this occurred, maybe where there was no clinical diagnosis. So looking at the impact then this had on things like operating times and patient length of stay post-op. We also looked at things like the range in patient BMI at a consultant level, again, to try to understand any correlation, I suppose, between this and then things like operating times, patient costs and length of stay as part of their spell. We also looked then at day of admission. So again, this looking at this against, the length of stay and patient costs, as well as breaking that down by age band. And you can see a couple of the outputs on the right-hand side there. And a natural next step for this work really is to bring it together with patient outcomes to have that wider conversation around value. And as part of the project, colleagues actually in Cardiff and Vale University Health Board are taking this forward to explore some of the further insights around this. So that's just a quick run through some of those tools and techniques on the back of some of the system level stuff that Lisa spoke about earlier. And as I say, some examples really of where and how we've tried to apply these at the national level. But also in saying that, I want to say there's still a lot of really good work going on locally within health boards as well. So there's a lot of stuff like this going on across the system in Wales. I just wanted to finish off this session on costing and value, costing for value, by briefly mentioning the upcoming launch of a value finance toolkit that we've been developing in recent months. And it's something that when launched will be a resource that's actually available to staff across NHS Wales. And the purpose of the toolkit, as you can see on the slide there, is to support NHS Wales finance staff, although not exclusively, to develop and deliver robust value programs that deliver the best outcomes for patients and maximise the use of resources. And you'd have just seen some small snapshots of that as we've gone through the presentation. And the idea of this really is, as I said, to equip finance and non-finance staff with some of the sort of tools, techniques and knowledge around implementing value-based healthcare within their own organisations, and as a way of supporting then that wider value agenda across Wales. And as you can see on the right-hand side there, it covers things from, what is value-based healthcare and why do we need it in a broader context, the role of finance in delivering value-based healthcare. We'll hear a bit more from Glyn on that in a short while. Some of the methodologies and tools, with some worked examples and tips on how we can do this. And then we at the end of the toolkit, we start to look at then, well, how do we use outcomes and costs together to understand value, and how do we bring that together to support, I suppose, that value-based decision making then at a local level. And the idea is that this will be a first draft of the product. It's something that we will look to continually update over time. I suppose as our understanding of value-based healthcare develops across Wales, and really to ensure that we can continue to, I suppose, share the learning as widely as possible then across the system. And we'll also be developing a suite of case studies to go alongside this, as well as other tools as things progress. So as I said, this will be coming soon, and for any NHS Wales colleagues on the call, the initial launch will be on the back of the Value and Finance webinar through the Finance Academy on the 3rd of November. So if you're not already registered for that, please come along. Hopefully it'll be an interesting session. And finally from me, I just wanted to show you very quickly a few of the national projects that are currently ongoing across Wales from a finance and costing perspective, really just to give you a bit of a flavour of what work is currently underway. I won't go through them in detail, but they're just there on the screen now, just to flash them up. So you'll be glad to know that's it from me, but hopefully that's given you, as I say, a bit of a flavour really of some of the things we've been exploring on the costing and finance agenda in Wales. And personally, I'm quite excited, to see how this agenda continues to develop going forward as part of the wider value programme. So I'm now going to hand you over to Glyn. Glyn is going to give us a finance director's perspective on the wider role of finance in delivering and driving forward this value-based healthcare agenda. And again, from his perspective, working then in a local organisation. So Glyn, over to you.
Okay, thanks, Craig, and thank you for the introduction as well, and good afternoon, everybody. So I'm just going to talk for a few minutes about how applying a value-based approach is absolutely core, I think, to the work of finance teams, and particularly to those finance professionals who are involved in business partnering roles, working alongside clinical teams in the NHS. So for me, I think finance teams should not view value-based healthcare as an additional chore to what is an already busy day job. If you think about the private sector, delivering increased value for the customer gives you the competitive edge to be a successful business. So whether it's a service or a product that you're producing, ensuring that it provides high quality and quality in the eyes of the customer is key to success or failure in the private sector. In public services, such as the NHS, delivering better health outcomes for individual patients or improving the health of the wider population is absolutely key to what we're about. So aligning our resources, particularly our financial resources, in the best way to achieve that should be our prime objective. And if you think about it, it's really the only way that we're going to sustain the type of healthcare system that we've grown used to and cherish. So I think the case for finance and the finance function to be a core part of applying value-based healthcare is very, very clear. So I'm going to talk about the role of finance in value-based healthcare, and I'm going to start off talking about leadership. And I think it's probably fair to say that finance teams have a really privileged position in most organisations, whereas finance professionals, we can actually see and influence things across the whole of the organisation. Finance professionals are well placed to lead the use of value-based healthcare principles, particularly when health bodies are planning and designing services, and they need that support in best allocating resources to make those plans and services a reality. So for senior finance leaders, reviewing how their finance function operates, there's an opportunity, I think, to reduce the amount of time that finance teams often spend on things like retrospective reporting, transactional work, and freeing that up so that actually finance professionals can spend more time working with clinical teams on making better use of resources. And alongside that, actually understanding the service, understanding the needs of the patient, and considering how resources can be used in the most effective way. But that requires real leadership from good finance professionals in their organisation to influence the work that they do and how they do it. But there is a clear role there, a leadership role for finance professionals. I'd then like to talk about the technical skills. Finance professionals generally have really strong technical skills. Craig talked earlier about TDABC. Most of us will have done activity-based costing as part of our finance professional qualifications. We'll all be familiar with how to apply it. And the opportunity to apply that in a healthcare setting is almost limitless, really, in terms of aligning financial resources and costs with outcomes that matter to patients. I also think that finance professionals have generally really good analytical skills, and they also have the insight to actually inform and influence decisions. So I think a good finance function will be able to provide that technically competent finance business partner that can get in alongside clinical teams and operational staff to understand how their service works, and then advise and influence on how they measure the use of resources alongside measuring patient outcomes. And that is the value equation that you saw earlier on in the slides. Finance business partners, if they're located with their local business units, are really well placed to actually assess what level of costing information and wider intelligence is required. And again, Craig alluded to this in the slides earlier. You can take a very detailed TDABC approach to providing detailed costing information, or you can rely on some of the PLICS and costing information that we produce routinely, or come up with a blended approach. And I think the finance business partner needs to be central to being able to identify what is absolutely needed to inform clinicians when they're making those decisions about making best use of resources. particularly looking at resources across the patient pathway. The way that we've set up our finance function is to have finance business partners working along frontline services, but where they require the more technical advice and support, that can be provided through a more specialist finance role. And that ensures that we've got good quality data, the integrity of the data is there, and they can support finance business partners in actually taking some of that work forward. And I think the finance toolkit that Craig and Lisa have developed will actually provide a great resource for both finance professionals, but also other people within the service to actually lever value-based improvements and shifts in resources. The third area that I just wanted to talk about and build on really was that role of the business partner and change agent. It's really important, I think, that finance functions actively develop those roles. And if you think about the COVID-19 pandemic, the number of changes that we've had to adjust to and react to as national health services, I think it provides a great opportunity for health bodies and also finance professionals to consider and make changes to services which will actually benefit patients. So we need finance professionals with good interpersonal skills who can build relationships with clinical teams, understand the services, what the patient needs, and then be confident to provide the professional challenge and support based on good data and information, which is what Craig and Lisa talked about earlier. It also means we need to be prepared to work across some of our traditional sort of organisational boundaries and structures. So typically, we've tended to work in divisional, directorate, specialty-based structures. But actually, if you really want to understand what matters to the patient, you need to work across a patient pathway or a cycle of care. And therefore, as finance professionals, we need to help the organisation understand how resources are aligned across that pathway of care, which will very often straddle a number of different divisional or directorate structures. So I see a finance function that does the basics really well, but actually considers applying value-based healthcare and the way that we distribute resources as a core part of their role. And I think this approach is very much recognised in the priorities that the NHS Wales Finance Academy has in helping to not only do the financial basics well, but actually look at how we develop good business partners that understand the value-based healthcare principles. So all of those components are really, really important. So my final slide hopefully starts to bring some of this together, and what I've tried to put in this diagram are a number of the things that we often end up having to sort of grapple with, and you could probably add another 10, 15, 20 bubbles to the ones that I've got on this diagram. When I talk to healthcare staff providing healthcare services, and bear in mind they're often under significant pressure, part of the solution is actually to have somebody alongside them that's got those good planning, analytical and communication skills to actually help them identify and implement the solutions. So finance staff can actually play that role. As I said before, they're well placed in terms of working across organisational structures. And identifying the resources that are used across that care cycle or pathway will allow each organisation to then map resources to the patient's care. So along with actually being able to measure outcomes for patients, that allows us to actually identify the value equation and actually improve overall value for the patient. That can be done at an individual patient level, and the finance team can enable clinicians and patients to make better use of those resources by measuring outcomes as well. At a population level, it also allows us to make more strategic decisions about where we can try and release resources and then reallocate resources based on the knowledge we have around improving outcomes for patients. So just to summarise, I think the Value Finance Toolkit will be a key component as we go forward, but finance professionals already have those skills and they already have the opportunity to actually lead in joining the dots for our clinical teams to actually map all the resources along the patient pathway, to identify where and how resources can be reallocated alongside measuring changes in outcomes for patients. So happy to talk more when we have the question and answer session, but for the time being, I'll pass back to Alan. Thanks very much for listening.
And thank you, Glyn, and thank you, Craig and Lisa, for a very comprehensive journey, I think, about all the work that's going on across NHS Wales, and really encouraging to see both the breadth and the depth of that work. We've got some time for questions. There's been quite a few questions coming in, so could I just start with you, Glyn, and probably a little bit where you left off, about the really tricky issue about the evidence tells us we need to move money across our services, but we seem to be constrained often by a budgeting process that seems to get in the way of people's ability to do that. So have you got any sort of advice, and is there any sort of approaches or solutions that can help with that? Do we need to do things differently?
Yeah, I think that's a really good question. And I mean, in practice, we often know that there are very often short-term, in-year financial pressures that mean we need to sort of try and achieve the financial balance whilst making sure we deliver all of the short-term service objectives. And I think probably every year that goes by, we try and look for those sort of short-term opportunities within fairly narrow budget areas, which naturally will lead us to looking at sort of short-term cost reduction measures without necessarily always looking at what it means for the patient, what it means in terms of impact on quality of care provided. And interestingly, I mean, if I reflect on sort of the last few years, I've actually found myself having to revisit a lot of decisions that we've made in the past, where we've made short-term decisions about reducing costs, taking out certain types of cost and spend, only to realise that actually they were probably a really valuable part of delivering the pathway of care. Sometimes they were the easiest things to do at the time, or rather it felt like they were the easiest things to do at the time. But actually, if you put them back into the pathway of care, it allows some of your more expensive resource to do the right thing and deliver the right care at the right stage of the patient's pathway. We often talk about professionals operating at the top of their license. And again, what we've very often done is taken out some of the smaller input costs to save money in the short term, only to find that actually they free up those more expensive resources. So I think one of my responses would be think very carefully when you're looking at fairly narrow budgets about the impact of some of those fairly isolated sort of cost reductions. And what we need to do is take that more pathway approach to looking at how we can improve efficiency and effectiveness. So, and that's something that we've done very much in this health board, is to start looking at pathways of care, recognising that actually they span a number of budget areas. You then need to get budget holders to work together along the pathway of care, understanding how outcomes for patients are affected if you take out certain resources or move them around. And I think if you just go back to the theory and the evidence around value-based healthcare, it talks about actually a lot of the short-term measures that we've taken have not only sort of caused sort of limited results in terms of benefits at the time, but actually have caused us to have to sort of reassess what we're doing. And really the only sustainable way of delivering healthcare going forward is to look at longer term use of resources where you can see clear evidence that it will improve outcomes for patients. So I think the case is very, very clear. It's taking that time to take a step back and to work across budget areas and budget holders aligned pathways that will allow you to do that.
Thank you, Glyn. That's very helpful. Could I pick up another question? And I think this one is probably best for you, Lisa, that we're very used in the NHS to benchmarking costs, but how do we benchmark value across Wales?
Thanks, Alan. That's a really good question. So value-based healthcare is a new area. And we very desperately want to understand how our costs and outcomes of service compare to other organisations. And so I feel quite privileged to be working in Wales at this time because we've got a really strong national value programme and lots of national projects where health boards tend to work together in order to understand the value of their service delivery. So I think we do tend to have quite a collaborative approach. We're learning as we go along, but there are instances, as Craig mentioned, with things like knee replacement pathway, cataract pathway, where we've done some collaborative all Wales work to learn from each other and then eventually to take back that learning to our local organisations and improve the value of the healthcare within those organisations. And also, I think it is a sort of a worldwide emerging area that people are looking at. So as we progress and as we talk to other countries more who are on this journey too, I think then it opens the doors for making communication with other countries who might have some good information that we want to understand and benchmark and work alongside them.
Thank you, Lisa, and I think that's a really important point as value-based healthcare is sort of spreading worldwide, a real opportunity to work with many more international partners and possibly not just limit ourselves to comparing what goes on in Wales. I've got time for one last question, which will probably be for you, if that's okay, Craig, which is a question around warranted and unwarranted variation and pathways, that the example you used of cataracts showed a lot of difference when you use time-driven activity-based costing in the way various parts of the system allocated its workforce. So two parts to that. How do you know which is the right one, which is warranted and which is unwarranted? And the second part of that is, could working with the chief operating officers and their operational managers help you with some of that challenge?
Okay, thanks, Alan. Yeah, no, it's a really good question. I think in terms of the first part, so the warranted and unwarranted variation, you know, when we look at costs, you know, naturally with different services across different organisations, that'll, you know, inevitably bring variation in the figures there. I think in terms of understanding whether that's warranted and unwarranted, you've got to look at it alongside the outcomes and what that means for patients. You know, and that's just one of the key things with value. It's not about costs alone, and that might mean different things in different service areas, even different parts of the the country, depending on what you're looking at. And I think it's about bringing that into that local context and really understanding the services and the needs of the population. But as I say, bringing together that whole sort of understanding of costs and outcomes collectively. And the second part, in terms of the chief operating officers and support with that through the organisation, you know, the process itself with the costing TDABC, for example, you know, naturally brings together, as I said, you know, clinicians with managers at that operational level. But I think it's certainly key in any organisation that you have that buy-in at the top as well, and there's got to be, I think, that drive from a board level as well to want to drive the culture and the appetite within organisations for this. And I think, you know, chief operating officers, you know, finance directors, you know, Glyn, for example, would be in his position in Aneurin Bevan, you know, a key part of the the team that leads the value-based healthcare across the health board, and the sort of positive messages around that. So simple answer, sorry, yes, I think it certainly will, and I think it does need that drive, but you also need, as Glyn was saying, then the teams on the ground, both the clinical management and the finance teams, and finance business partnering teams in particular, really involved in that to really drive the agenda going forward, I think.
Thank you, Craig. Unfortunately, we seem to have run out of time. There are a lot more questions that have come up this afternoon, and we're going to endeavour to try and answer all of those. And it's just a shame that we couldn't have spent a little bit more time exploring some of those in a bit more depth when we've got the panel all together here. But we've come to the end of the session. Could I just take this opportunity to give a huge amount of thanks to Glyn, Lisa and Craig. That was fantastic. Congratulations on all the work that you're leading across NHS Wales. I think it puts us in a very strong place, not just to deal with all of the various problems that COVID has brought, but certainly set us up to deliver on the broader strategic objectives that we've described in a healthier Wales, where value-based healthcare is very much at the heart of that. So thanks very much all of you for your time today. Thanks everybody who's tuned in today to listen to this session, and there is a lot more sessions going on for the rest of the week as part of Value in Health in Wales, and I'm sure in some of those sessions you will also see little bits of some of the work that we've picked up today when we've looked at this more from a finance angle. So thanks very much everybody for your time, and I hope you enjoy the rest of the week.